Hello everyone. Today I'm going to talk about hypertrophic cardiomyopathy. But first, I would like to say in our course, we are trying to cover a variety of topics which are relevant to our audience. So please, if you have any suggestion for any topic to be covered, let us know in our WhatsApp group or leave a comment on this video. And now, let's get started. I will start with a brief introduction about hypertrophic cardiomyopathy, which is a genetic disorder characterized by left ventricle hypertrophy without an identifiable cause. And the first thing you need to know about it is that hypertrophic cardiomyopathy is the most common cause of sudden death among the youth and athletes, particularly the intense competitive sports practitioners. In addition to that, hypertrophic cardiomyopathy is the most common monogenic cardiovascular disorder. Hypertrophic cardiomyopathy is inherited in an autosomal dominant pattern associated with mutation in 11 or more genes encoding proteins of thick and thin myofilament contractile components of cardiac sarcomere or Z-disc. A comprehensive clinical description of the disease was first made 55 years ago by the Braunwald group at the National Institutes of Health. At that time, it was called idiopathic hypertrophic subaortic stenosis. However, it was a rare condition. It was a condition with an ominous prognosis and limited management options. Thankfully, things are different now, and hypertrophic cardiomyopathy is now recognized as a worldwide, relatively common, and treatable form of genetic heart disease that often does not affect life expectancy. Now let's talk about the epidemiologic features of hypertrophic cardiomyopathy. Echocardiography-based epidemiologic studies has shown a disease prevalence of 1 case per 500 person in the general population. But with clinical and genetic diagnosis, the prevalence is 1 case per 200 person. With this prevalence, there is an estimation that 750,000 persons in the United States may be affected by hypertrophic cardiomyopathy. However, the disease has been diagnosed in only a fraction of them. As you can see on this graph, only 10% of people who are suffering hypertrophic cardiomyopathy are diagnosed. 60% of the diagnosed patients are symptomatic, but the other 40% are not. Hypertrophic cardiomyopathy has been identified in 122 countries, which representing approximately 90% of the world population. This gives us an estimated number of 20 million people who are affected globally. So, how to diagnose hypertrophic cardiomyopathy? First, we can diagnose it by echo and MRI. However, MRI can provide a more reliable assessment of the left ventricle in some patients. Second way to diagnose it is by doing genetic testing, and this way is confined largely to next generation family screening. What we are expecting to see in echo or MRI. First, left ventricle hypertrophy. In most clinical diagnosed patients, left ventricle wall thickness is 15 mm or more with average thickness of 21 mm. If the thickness is between 30 to 50 mm, this can be considered massive thickness. But if the thickness is 13 or 14 mm, this would leave us a bit confused with another diagnosis like systemic hypertension or physiologic athlete's heart. Keep in mind two things. First point is that any hypertrophic cardiomyopathy patient is a gene carrier, even with normal dimensions. Second point is that greater left ventricle thickness is associated with an increased risk of sudden death, but not necessarily of progression to heart failure. The second thing we are expecting to see is the outflow obstruction. Hypertrophic cardiomyopathy is predominantly an obstructive disease, with 70% of patients having mechanical impedance to left ventricle outflow at rest or with physiological provocation. So the gradients will be equal or more than 30 mm mercury. Now let's see how the patient presents with hypertrophic cardiomyopathy. And I will start with patients who remain free of clinically significant symptoms and adverse events. Then symptomatic patients and the patients with complications that will be mentioned later, up to sudden death. How to manage hypertrophic cardiomyopathy? And the management here will start with avoiding the complications. First complication is the sudden death. So how to avoid sudden death? Several clinical markers have been assembled into a risk stratification algorithm in accordance with consensus management guidelines published by American College of Cardiology and the American Heart Association and the National Institute for Health and Care Excellence. This strategy has been highly effective and sensitive for identifying the vast majority of individual patients at increased risk for sudden death. In whom subsequent device therapy reliably terminates ventricular tachycardia and fibrillation. Prophylactic defibrillator placement should be considered for young and middle-aged patients whose clinical profile include one or more conventional risk factors judged to be major. Defibrillator interventions effectively terminate ventricular tachycardia or fibrillation either as primary prevention or as a secondary prevention after the patient survived cardiac arrest. Surveys show that patients with hypertrophic cardiomyopathy who undergo treatment with defibrillators report acceptably low level of anxiety and depression, which means that they are feeling more safe with this small device. Second complication to be managed is the heart failure. That can be obstructive heart failure or heart failure without obstruction. I will start with obstructive heart failure, and in patients with hypertrophic cardiomyopathy is often accompanied by pulmonary hypertension, diastolic dysfunction, and absence of an increase in stroke volume with exercise, which is potentially exacerbated by extrinsic factors like obesity. And to manage this kind of heart failure, we have two options. First, pharmacologic therapy. Many such patients have a favorable response to pharmacologic therapy, with symptoms controlled and restored quality of life for varying periods of time, despite not adding new drugs over the last 30 years. So we are using beta blockers, calcium channel blockers, and disopyramide. Second option is the invasive one. So we can do either myectomy or percutaneous alcohol ablation. Patients with disabling symptoms and an impaired quality of life, particularly those patients with NIHA class 3 or 4, due to long-standing left ventricle outflow obstruction at rest or with physiological provocation, are candidates for primary transaortic septal myectomy, performed to abolish the gradient and mitral regurgitation. As we can see here, the left ventricle outflow tract is very narrow with high gradients, so we will cut this part of myocardium to decrease the subaortic gradients and terminate any restriction for the blood flow. It is one of the safest open heart procedures with an operative mortality of 0.4% in centers with a high volume of obstructive hypertrophic cardiomyopathy cases, representing a 95% reduction in mortality from 35 years ago. However, the risk of operative death is increased by a factor of 12 when myectomy is performed in centers with a low volume of such cases. Myectomy is associated with long-term survival, equivalent to that in the general population, including a possible reduction in the risk of sudden death. Second invasive option is the percutaneous alcohol ablation with myocardial contrast echocardiography, and this procedure can be considered the primary alternative to myectomy. And it is usually reserved for selected patients of advanced age with severe symptoms that are refractory to drug therapy who are not candidates for myectomy, and patients who do not require coronary artery bypass grafting or valve replacement. So in this procedure we are doing iatrogenic alcohol-induced transmural infarct mimics the effects of myectomy on gradient and symptoms. So what are the advantages of this procedure? It is less invasive procedure and requiring a shorter hospital stay. Survival rates are similar to those for myectomy. Now let's talk about the disadvantages. 10% of patients who undergo alcohol ablation require a pacemaker for heart block, and the arrhythmic burden may be increased in vulnerable patients because of the septal scarring. 10% of patients require repeat ablation. Unfavorable anatomy of the left ventricle outflow tract and septal perforator artery may limit treatment efficacy. Successful alcohol septal ablation depends on high operator volume and technical expertise in a multidisciplinary hypertrophic cardiomyopathy center. So, what about heart failure without obstruction? Such patients are mostly in stable conditions, usually with preserved systolic function, only mild heart failure symptoms or none, and a generally favorable prognosis. Cardioactive drugs have beneficial effects on symptoms. A minority of patients without obstruction at rest or on physiological provocation have progressive end-stage heart failure that is refractory to maximum medical management and may ultimately become a candidate for heart transplantation. Last complication that need to be managed is atrial fibrillation. Atrial fibrillation is the most common sustained arrhythmia in patients with hypertrophic cardiomyopathy. However, atrial fibrillation can increase the risk of embolic stroke by a factor of 7 in hypertrophic cardiomyopathic patients. It does not increase the risk of sudden death or progression of heart failure. The frequency of symptomatic atrial fibrillation can be reduced with the use of antiarrhythmic drugs, catheter ablation, or the mass procedure combined by myectomy. I hope you enjoyed our topic for today. See you soon with another interesting topic.